dear listeners. Welcome back to another new episode of ISST's podcast series, Digital Dilemma. Today's episode is quite special because this particular study of ISST has been done by a very dear colleague of mine, Sreerupa. Hello, Sreerupa. How are you feeling today?
Hi, Anweshaa. Great to be here with you.
Fantastic. So Sreerupa is a research fellow and program lead at ISST. She holds a PhD in economics from the Center for Development Studies from JNU, New Delhi. At ISST, Sreerupa leads the team on informality, precarious work and care, which focuses on exploring intersections of labor precarity and care dynamics, and has worked extensively on elderly care in Kerala in India. Her research delves into new avenues, shedding light on contributions of informal workers in the circular economy and the experiences of accredited social health activists or ASHAs in healthcare digitalization. And today we will largely be speaking around the digital dilemmas faced by ASHAs based on the findings of the report Digitalization at the Frontlines. This report is very interesting. It captures the ASHA's interaction and experiences of digitalization across four diverse states in India, namely Haryana, Kerala, Rajasthan, and Meghalaya. There is also a wonderful comic book available in English on ISST's website, which has been drawn from the findings of this particular study. There are certain other inputs and outputs from the ASHA study, which Sreerupa will speak about. Let's begin with a bit of context setting, with a strong push for digitalization, particularly through initiatives like digital public infrastructure, DPIs. We have seen that digitalization has become a very important aspect of improving efficiency of informal work as well, and especially in the case of scheme-based workers like ASHAs. So while it's being promoted as a tool of better governance and transparency and efficiency, how does this policy vision align or clash with the lived experiences of ASHA workers on the ground? Thank you.
So thanks, Anweshaa. Let me start by giving slightly broader context of the digital transformation, particularly within the healthcare sector. That's one of the recent World Economic Forum article highlights India's potential to become a global leader in digital health by building a resilient digital health ecosystem. So many of us might be familiar that since 2017, India has actively pursued digitization of its health ecosystem, which was started by policies like the National Health Policy. And in 2020 was particularly important because we had the National Digital Health Mission, which was launched to establish a secure and comprehensive national digital health ecosystem, which was later renamed as the Ayushman Bharat Digital Mission, which we are more familiar with. So what we've observed over the years is that there has been clearly a significant policy push to integrate digital public infrastructure into public health governance. And we saw this and heard about this in the discourses that were prominently showcased during the India's G20 presidency. So I wanted to start by impressing upon this larger context within which the digital transformation is happening. So now coming to the question of how this digitalization is seen as being important for the informal workers, particularly the scheme-based workers like ASHAs. If you think about this, the fundamental idea really is, and the belief is that technology can somehow improve the way things work and can make everything more streamlined, more efficient, reduce leakages, even improve the service delivery. Not only that, even the government and governance can be made more efficient, right? That's where this huge initiatives like the Ayushman Bharat Digital Mission really come in, because it envisions this grand digital ecosystem for healthcare. But what we must pause and kind of understand and take in is that all of this is very firmly grounded in a neoliberal ethic of data-driven governance. And the idea here is that technology is a silver bullet or is an answer to all the kind of developmental woes. The underlying belief somehow remains that, and the hope is that all of this trickles down and benefits the women workers who are at the bottom of this healthcare hierarchy. So what we've seen is that a lot of effort has been made to make some of the digital tools accessible to the ASHAs over the years, such as the smartphones, a number of health data collection apps, and access to different kinds of digital platforms have been brought about. All of this seems to be pushing towards modernizing the community healthcare system.
And I think this is something that has been coming up in almost all the episodes of Digital Dilemma, is how technology is is a silver bullet that is going to end all our woes. But, adaptation to technology is a whole different story. Who designs, what comes down, who uses, how do they use it, how do you adapt to technology. I think, and that has been beautifully laid out in this study, understanding the gendered experiences of ASHAs in using and adapting this technology. So, please introduce your study to the audience here. I'm actually, quite fascinated also on how you had selected these four diverse states, because each of them are very different from each other. And a lot of thought has gone into selecting states as well for this particular study. So, can you tell us a bit more about the research methodology, the objectives, and overview of the study?
I think given this kind of a context of the changing world of work, for the informal workers, the scheme workers of the public health system, we started out with a few, critical questions. So our research on ASHAs really emerged from our thinking in the post-pandemic years, that how is this rapid digitalization of healthcare really transforming the lives of the frontline women workers? And more so, as feminist scholars ourselves, we were very keen to understand or visualize who's really shouldering the burden of digitalization, whose labor goes into building and sustaining these digital infrastructures, and really at what cost. And how do these shifts impact women workers? Does it enable them? Does it increase their agency? Exacerbates their vulnerabilities and precarities? Because we realize that this has profound implications, particularly for all the frontline workers like ASHAs. ASHAs are basically accredited social health activists, are the community health workers in India. They have played a very important role in being the critical link between the underserved rural communities and India's, a huge public health system. They were introduced into the public health system in 2005 under the National Rural Health Mission. Their key responsibilities included maternal and child health promotion, immunization drives, and raising awareness about public health schemes, among others. But despite the very, very important and indispensable contribution that these ASHAs had made to the public health system and in achieving a number of, important public health outcomes, these community health workers' labor has over the years been systematically devalued. They only have the status of a voluntary worker. What we also saw during the pandemic was how some of these frontline workers across the globe and including in India were, celebrated. And we know that WHO particularly had honored the ASHA workers of India during the pandemic. But this all women cadre of honorary volunteers, we must remember, come from particularly marginalized, communities. We also thought that it is important to be cognizant of the fact that there isn't even a single voice that we are trying to amplify. And the frontline women workers themselves are not a homogeneous group. Their experiences are shaped by their identities of caste, class, religion, age, education, and geographical locations, which influence their experiences. So, recognizing this diversity, we basically use the feminist intersectional lens to ground our research in a worker first, bottom up perspective, which prioritize the lived experiences of ASHAs over the dominant tech centric narrative. So, with this in mind, we started off with a very intensive scoping study, which we did in Haryana. And one of the reasons for picking Haryana for our research was that there was a lot of strong collective action of the ASHA Workers Union that was happening in Haryana, which had gotten a lot of attention, wherein, there was surveillance app called the MDM 360 Shield app, which was imposed upon the ASHA workers, and they were asked to download that into the smartphones provided to them by the state. And the ASHA Workers Union had realized that, or rather perceived that there was a lot of surveillance potential of this app, which could track their location, it could control the access that these workers had to different apps, and it could also edit or delete some of the data that they entered into the system. Through their collective action at a time when even, personal data protection was not being spoken about much, these ASHA workers were able to resist and push back an app which they thought was, harming and was controlling their data. So that was something which we thought was an important kind of a moment in how the ASHAs and the workers' union was experiencing and kind of negotiating to this changing world of digitalized work. And through that, we decided to start this scoping study in Haryana. But very soon, through our research, we realized that there is a huge amount of diversity in the way that digitalization has been experienced and the way that digitalization was impacting the workers as well as their world of work. And to kind of fairly represent a hugely diverse country like ours, it was very important that we also looked at the experiences in at least in other parts of the country. And to get a more regional representation, we extended our work to the other states like Kerala, Rajasthan, as well as Meghalaya. The thought process behind picking these four states was we wanted to look at states which were much more nascent in their adoption of digitalization. We wanted to also pick Rajasthan, which was one of the pioneers and had started the digitalization process of ASHA's work right at the beginning. And we wanted also experience from a state which has much more decentralized governance ethos in the way that it has been functioning. So with that, we made our selection for this state, and it has been a much rewarding research project because it really revealed the huge diversity, the whole spectrum of digitalization that is there.
I think the state selections were very interesting and the process, and it's all there in the report, how you sort of did the scoping and why you selected these states. And as you explained, the diversity of each of these states also impacted the kind of, levels of digitalization, the adaptability of digitalization also changes, which we'll speak more about in the episode going forward. I would like to ask you very briefly about the methodology. Well, this was a qualitative study and there were FGDs and key informant interviews, in-depth interviews. But Sreerupa, I think the workshops that you did, the kind of data that has come up, I think was very interesting. So very briefly, if you could just speak about that before we move on to the findings of the study.
Since we are speaking about the methodology, I think the methodology for this study was, in fact, quite unique because, as I mentioned, we started with looking at one state and realizing that if we had to capture the experiences, we had to look beyond, Haryana and look at some of the other states. We were also faced with limited resources of funds and time. So what did we do? So we basically innovated and we adopted what a more agile and innovative dipstick research methodology, which basically built on the rigorous scoping study which we did in Haryana and expanded it to the other states with very short bursts of intensive fieldwork in the additional states of Kerala, Rajasthan, and Meghalaya. And we believe this approach is also replicable and can be effective to conduct broader research in resource constrained settings and for research which is time sensitive. And we have more detail on this in the report for anybody who's interested to learn more about it. And one of the strengths of the methodology was also that we used multi-method qualitative research method, including in-depth interview, focus group discussion, participatory activity mapping exercise, consultations with the unions, as well as key informants with the public healthcare system. The workshop with the ASHAs, I think, was a very critical element of the study because we were very clear that this is a study that we are also doing with the workers. So after our rigorous scoping study in Haryana, we wanted to take back the findings of our research and share it with the community of ASHA workers. And then I particularly remember because we started with an art-based activity with the ASHA workers, nudging them to really express how do they experience the smartphones personally as well as in their professional work life as an ASHA. Continued that process in all of the different states that we went to. With the fieldwork, we always made sure that we had this interactive workshop with the ASHAs where we shared the experiences of digitalization that we had already documented from the other states. And something that was very revealing for many of the ASHAs were the gender norms around the access and use of technology. And particularly, I remember the ASHAs from Kerala and Meghalaya being very surprised that the ASHA workers from Haryana found it really difficult to use smartphones in their day-to-day work, particularly in public spaces. So these ASHA workers, when they were using smartphones on the road for their work to pick up calls, to communicate and coordinate with either the community or the health officials, they had to be very conscious that they are not seen as using a smartphone on the road. I remember one of the ushers saying that, if they are found using smartphones on the road, then there will be talk about कि अरे इनकी बहू तो कान पे फोन लगा के घूमती है, पता नहीं इसके कैसे कैसे काम चल रहे हैं. So there was this notion about what a good woman should behave and what are the boundaries around it.
And I think these are some of the digital dilemmas. While we are going to digitalize, but what do you do around norms, around digitalization?
About the access bit, the real thing is now that the government is pushing more and more to bring access to not only ASHAs, generally to women through various schemes in different states. We know that ASHA workers are being provided smartphones in different states. But when we are giving physical access, the question really remains, is physical access alone enough? Or as research scholars like Radhika Krishnan have talked about, that that's only a mechanical access. If you want meaningful access for these women and women workers, then we need to see changes in social norms.
Absolutely. And be aware that there is a backlash that might just happen. Oftentimes it's so top down that you would just give smartphones and expect people and women to just start using it, adapting it because it's part of their quote unquote work. But there can be some serious backlash as well. In your findings, I think these have come up, very crucially. And so, just moving on to our next question, and what has shifted with digitalization? There was a primary work that they have been doing, and then there's this layer of digitalization and the nudge to quickly adapt to it. So, what is being shifted in this?
As I mentioned, with this digitalization, what has happened is one, making accessible a number of digital tools. Like some of the states, like Haryana, gives free smartphones to the ASHA workers. And there has been a flurry of health data collection apps that has been introduced, through which the ASHA workers have been kind of lured into this digital data collection drive for the state. And the important thing to keep in mind is now increasingly, good data is being equated to good healthcare delivery. And it is within this exercise that the ASHAs have been introduced to multiple digital platforms. So what we see is definitely a transformation around the work of ASHAs. What we must also admit is that the digitalization has enhanced their access to technology. It has improved ease of communication, and in many ways has increased efficiency in their work. If I may just kind of give you an overview of the different kind of tools that the ASHAs use, there is a range of applications or tools that have been made available to the ASHA workers. On the one hand, the ASHAs have been introduced to an ASHA Pay app, which is basically a digital platform for ASHAs and their incentive claims. The idea is to reduce the paperwork involved in claiming their incentives, and to make it much more streamlined and efficient. Other very important transformation that I've seen that has happened for the ASHA workers across the different states has been the introduction and the use of WhatsApp. So WhatsApp is being used intensively for all kinds of communication and coordination that happens with the health officials, when the health officials have to communicate any kind of information about meetings or any awareness campaigns that need to be run in the state. And also the ASHAs have started using this for the communication with the community as well. The other is an array of digital survey apps. For example, let me speak about the Haryana case, where there is the ASHA Sarvekshana app, which was a digital survey app related to COVID-19, the Ayushman Bharat app, which is to help make the Ayushman card for members of the community, the digital survey on disability called the Divyang Sarathi app. There is a digital survey for NCD in the community. And then there are many apps like Zoom and Microsoft Team, which are used for training and meeting purposes. So with this different array of digital tools, the ASHAs are being pushed towards integrating these tools into their everyday activities.
So you have covered 4 states in your study, and as you mentioned right in the beginning, each of them are very diverse contextually, as well as the level of digitalization and the kind of digitalization. So if you could, I think, from your findings, talk about this various differences and the experience of digitalization of ASHA workers across the 4 states.
Yes, totally, Anweshaa. I think one of the biggest takeaways for us from this research was that there was a spectrum of digitalization. which we became aware very early on during our scoping study, that the way that the digitalization has happened was quite uneven, and the way that it was impacting the ushers, the workers, and the responses of the unions was quite uneven, across the state. So, as I had kind of alluded to right at the beginning, we had started with a scoping study in Haryana. And what we noticed in Haryana was a very rapid pace of digitalization with a flurry of apps, which I just, shared with you about. What we also noticed during our field work was that there was this kind of a push for the ASHAs to really kind of transform themselves into what's been within quotes called as, become a smart ASHA, to become more of a professional and a digitally savvy data agent. So during one of our field visits and observation during a training review process that was happening for urban ASHAs in the National Health Mission, we noticed this conversation that was happening between the health officials, and how he was kind of, talking to the ASHA workers and trying to kind of inspire them and motivate them to pick up digital work. So he was alluding to how now the era is of a technological era, and that all the ASHAs now need to become a smart ASHA. And he mentioned how the government was providing them with a smartphone, which he referred to as their, personal assistant. And it was being done, all of this, to basically improve the quality of the data, and that they had to become more and more savvy in using these digital tools and smartphones. And he was referring to the neighboring districts ASHAs, how they had started, using these tools much more effectively, and it was transforming. But what did this all entail? We are wanting this transformation, but we have to understand what is the context. As I mentioned in the beginning, ASHA's program was started in 2005, and these were supposed to be community health workers, women who were selected from the community, who had, reasonable educational levels, maybe around 8th or 10th class pass, women who could mobilize the community when needed for different healthcare programs, and to create healthcare awareness within the community. So their critical role was to be this link with the community. And what we're seeing now is this kind of a shift that is happening. For a group of women who possibly don't have educational levels higher than 10th, with low levels of literacy, let alone digital literacy, another layer of work is being added to them by asking them to collect and maintain data digitally. So the context is also a larger lack of kind of trust within the digital systems, whether it is within the community, these ASHA workers themselves, or even within, the health system and the health officials, that many of them are asked to maintain both the paper records as well as the digital records. So which eventually burdens the ASHA workers with the double burden of both paper and online work. Moreover, there is the threat of heightened surveillance, as I mentioned, with the MDM 360 kind of apps that were introduced. So what we noticed that within Haryana, many of these ASHAs found this digitalization process to be very top down, very extractive, wherein, the whole idea is to collect more and more data from these ASHA workers, whereas they didn't feel as supported in their work, because the digital skilling, which could have really helped these ushers navigate or transform into this digital world, was unfortunately, not adequate. So there was a lot of challenges with the digital skilling programs that were there, because they tended to be much more driven by targets. And I remember, one of the health official kind of, sharing with us that there is a huge diversity within the ASHA workers that they have to work with. Many of them are illiterate, a number of them are old and find it difficult to, you can kind of, make a transition to the kind of digital work that's needed, and pushed by the kind of targets to that these health officials have to face, they at times choose to pick a more digitally savvy ASHA workers, or the ones who are better educated, and the young ASHA workers to train. And in this process, many a times the older ASHA workers, get excluded. So because of all of this, there was a lot of resistance among the ASHAs towards the online digital work that we saw in Haryana. And we saw that a lot of them were finding themselves alienated in this reimagination of their work and the role. Let me give you the other contrasting example of Meghalaya. And we picked Meghalaya because we also wanted to see a state which was quite keen to make the kind of a digital transformation in their healthcare system. however, was also faced by huge challenges of geographical and infrastructural limitations that the state faced. So it had very poor connectivity, extremely low levels of literacy that are there, hampering factors or barriers for the digital transformation which the state really envisaged. So, what we also noticed was that the senior health officials in the state were quite cognizant of the local challenges. So, what we saw in Meghalaya was a much more slow paced digitalization, a digitalization which was very nascent and fragmented in many ways. The state did try to make certain efforts with digital skilling interventions, but due to the huge diversity of the population, different languages that are spoken, it was very difficult for them to bridge the linguistic barriers to reach all the different population that were living there. And also the literacy level and the digital literacy gaps were also not sufficiently filled by the digital skilling interventions that could be provided by the state. I remember when ASHAs from Meghalaya were speaking to us. Many of them felt very dejected that when they had joined in to do the ASHA work, they were only expected to do the community care work and do a lot of their work on paper-based forms, which they have now become very familiar and comfortable with. And they said that they're finding it increasingly difficult to navigate these smartphones and to use these smartphones, and often had to depend on the family members and children to be able to do the kind of work that they are doing. And some of them also expressed hope that maybe someday they would be able to pick up these skills. But currently, with the system that's there and the support that they have been provided, they find it very challenging. Having given this context of this Haryana as well as Meghalaya, this very diverse context, one where there is a huge top down digitalization process, very fast paced process of digitalization that has happened, and the other of a very nascent and fragmented digitalization in Meghalaya, we also found that there were very varied experiences. Like, for example, in the case of Rajasthan, which was really a pioneer in this process of digitalization. It had introduced apps like the ASHA Soft app, which is meant to digitalize the payment of the ASHA workers somewhere in 2014, and has over the years brought in, again, many different platforms have been introduced to ease the work of ASHAs. The most recent one is the PCTS app, which was introduced in 2023, and which we believe has been a real game changer, because PCTS app basically allows the ASHA workers to access the data which they collect. They can track the work that they have been doing and identify even opportunities for them to increase their earnings. So, because of this ability to be able to access and use the data to kind of support their community care work, ASHA workers have very enthusiastically adopted to the PCTS app. They have also mentioned very importantly that this has helped in building the trust and respect for them in the community, because what they're able to do is, suppose, for example, there is a vaccination drive that is going to happen in the state, then they get intimated about when the community members that they are kind of interacting with have the next vaccination due, and then they can inform the mothers about the due vaccination dates. They can also track when the payment or the incentive informing to any particular health program is updated in their accounts, and are able to pass on again this information to the community, which built a lot of trust and respect for these ASHA workers within the community. And because of this, they have appreciated. So in the case of Rajasthan, what we see is that the ASHA workers are not just reduced to data collectors, but they become then, in a sense, an active participant in the system, because they're able to track the outcomes of their effort and are able to feel more valued and supported in this whole process of digitalization. The other case study that we had picked up was of Kerala. Remarkably, what we noticed was that the pace of digitalization was very slow and intentional, wherein in some of the other states like Rajasthan and Haryana, we saw that there was an array of apps which were being introduced. Kerala really decided to focus on one major data collection app, which was the Shelly app for the NCD survey. Another important thing which really makes the experience of Kerala stand out was that there was already a robust digital skilling ecosystem in Kerala through the support of Akshaya centers. And Akshaya centers had made digital skilling accessible to all the citizens in Kerala, not only to the ASHAs. So what it did was that when the digitalization process was being introduced into the work of the ASHAs, they had a previous exposure and skilling to digital skills, and computer skills were already there. And since Kerala is also a state which has had a strong ethos of decentralized governance, we were very, very happy to note that there were these interesting, innovative experiments that were being done at Kerala, wherein there was attempt to bring in the ASHA workers coordinators and developers of the different digital platforms together over regular meetings, wherein the ASHA workers coordinators could share their feedback for the way that the new digital platform was being designed. So this basically, we believe, is a very, very important kind of an initiative, and which can be replicated and adopted by many other states, is to ensure that the digital tools that are being designed are basically tailored to the specific context of the community health workers and are responding to the needs of the workers, and their inputs are being taken in the way that these are being designed. Maybe if I try to sum up what has been the experiences of the ASHAs, although we have seen that there has been a huge diversity in the way that digitalization has been experienced based on the local context, as well as the way that the digitalization process has been really, conceptualized and implemented. What we really see is beyond doubt that there is reimagination of what an ASHA worker is, from merely being a community health worker who's the link between the state and the community. They are now being reimagined as technological workers as well. They are being nudged to transform into smart ASHAs. Imagination and the scope of their work has certainly increased by including digital data collection as part of their work. And what it really has meant for these ASHA workers who come from very marginalized communities, poor households, with very little exposure to any kind of digital skills and sometimes extremely low levels of literacy, is that many of them are facing digital exclusion based on their intersectional identities. And unfortunately, in many of the states, while the transition to digital is happening very fast, the pace at which the ASHAs really needed to be supported by providing adequate and customized digital skilling programs and support has not really matched up. The other thing which kind of something which really needs to be highlighted is how a lot of this digital work that the ASHAs are doing really remains invisible. And again, with this invisibility, a lot of this work also remains unpaid. So they play this important critical role in this building and maintaining of big initiatives of digital health infrastructure, but their critical role in data collection, in kind of, navigating and negotiating with this new technological tools in making this possible has really been not acknowledged. And the ASHA workers, although in many states they have been promised, do not receive any separate payment for the digital data work that they're doing. The one exception which I heard about was in Kerala, which I believe for the data collection that they do on the Sherry app, they are paid some nominal amount for that. So this remains a huge challenge, the invisibilization of their digital labor and the unpaid digital labor which they are providing. The other major kind of shift that we notice is how there is an increasing focus on digital data collection, sometimes at the expense of the community care work that they're doing. So there's a shift from focus on the community care work to digital data collection and more datafication of the care work, if we may, call it that. So particularly in the case of Haryana, we noticed that there was a lot of focus on, multiple digital surveys that were being conducted on the digital data collection exercise as such, in such a way that what happens is then the data becomes more important than the delivery of the care services itself. And I distinctly remember that, one ASHA worker, very, very concerned, she had told us that how some health officials had asked them to focus on the Ayushman Bharat cards, and even at the expense of the community healthcare work with the mothers that they were doing. On the other hand, we also saw if the digitalization is kind of, envisioned in a different way and is implemented in a way that it is much more worker friendly, for example, the way that it was done in Rajasthan, we found that the digital apps were in fact supporting the community care work that the ASHAs were doing, because the ASHAs had access to the data that they were collecting. They had more information about the due dates of vaccination and other initiatives that they were taking, and they could kind of streamline their work plan and could effectively conduct their community care work. We also noticed that when they are sufficiently supported and provided the right kind of skills, they also use the digital tools, like for example ICTS tools like WhatsApp, much more innovatively. We noticed that the ASHAs would create WhatsApp group with the community members or the mothers in the particular community, and would put up status messages of the upcoming healthcare awareness campaign or any other initiatives, and they could reach out to a much larger kind of community and much greater participation. For example, I remember this ASHA worker from Kerala spoke about how they had put up information on the WhatsApp about eye checkup campaign that they were going to run, and they got much more participation than what they had expected, otherwise. So we're seeing this, both sides really playing out, wherein if the digitalization is really not thought through in a way that it supports the workers, then we see that the community care work really suffers. But if it can be envisioned in a way that it supports the workers, is friendly to the workers, and it supports their community care work, then it can also be a great enabler for the ushers.
Thank you for giving us a fantastic overview of the context of digitalization in each of the states and how that sort of enables or burdens ASHA workers working, and how the digitalization process then sort of disrupts or again enables their work. And also for giving us this example of what does it mean to make it transformational, what does it mean to enable, as we see in the case of Kerala. I think another very important takeaway is how WhatsApp is being used, as means of communication, reaching out to more people, means of communications with different officials, with supervisors, between ASHA workers themselves. In each of our episodes, some of this, the power of WhatsApp has been very interesting, how it's being used by various informal workers. And as we can also see in this case as well.
I cannot agree more with you. There is a certain Whatformization of all of our work, where a lot of the work related communications, not only for these ASHA workers but for also many other workers like us, is happening on that platform. In many ways, it has eased and streamlined the communication, but we also need to consider the kind of power hierarchies that exist
Absolutely.
within which these kind of changes are happening, and what it does to these scheme workers. It has allowed a certain kind of digital availability, or rather there is this expectation of a certain kind of heightened availability, urgency, and increased reporting that has happened for these ASHA workers, where they have to be constantly available to respond to messages that are being sent to them over the WhatsApp, about meetings that are being fixed up on a short notice, about different data that's being asked for these ASHA workers to kind of produce and then report back to the health officials. So basically, this continuous pressure to be available on the phone. So there's this mental burden which a lot of these ASHA workers experience, and I remember distinctly this word dabav being used by ASHA workers in Haryana, where they felt this mental pressure of managing this heightened expectation of availability for their work, and what it really means for these women workers who have to not only manage these pressures of work, but also they have these domestic responsibilities, household responsibilities, and childcare responsibilities. So this whole spectrum of paid to unpaid to underpaid care work which they have to balance through the day, and which puts a huge amount of pressure on them and on their mental health.
I think another very important thing that you did speak about is being paid for the digital work, which you did see in Kerala but not in other states. How this is not just the kind of work you did, but it's also a separate sort of work, not to be looked at as in the same frame as, oh well, you are doing this work, you're just doing it in a digital format. But this is a lot of work. work, and as you have explained, the fact that there is this double burden of doing a paperwork, then transferring on to the digital mode, all of this takes a lot of time, energy, and mental burden and anxiety for women with different capabilities of different contexts to actually get onboarded onto the digital team as well. So the fact that there is digital work and it involves a cost and cost of labor, I think that that was also a very unique point that you've picked up here. I would like to now ask you a question around which we had just touched upon right in the beginning around surveillance versus worker autonomy. We did talk about the MDM 360 Shield app and how the ASHA workers in Haryana protested and brought down. It was a surveillance app. So while in some states, we do see that digitalization has led to increased monitoring and surveillance of workers, while we see in other states there have been more enabling. So what do you think? How do ASHAs perceive digital monitoring, and what are the implications for their autonomy and job satisfaction?
I think there is also another level of control that is there with the kind of a digitalization that we are seeing, which we just spoke about, is the increased availability. So basically, a worker's time who was initially with their introduction in 2005 were only supposed to be volunteers, who worked for like 2 to 3 hours a day in kind of supporting the public health system, in bridging that gap, in creating awareness and the community outreach, were now being asked to kind of available throughout the day, so to speak, and to be accountable, to be able to produce reports and the data as and when was being requested by the health officials. So there is an element of control over the ASHA workers, which ASHAs are experiencing. Wherever the process of digitalization has been very intense, with the flurry of apps that have been introduced, even in places like, for example, if I remember correctly, in Kerala, where we had only one digital app, but sometimes the ebb and flow of the digital work is such that these surveys have to be conducted in a very short period of time. And ASHA workers did mention that, because of that, they did feel the pressure of having to complete that work in a short period of time, having to, spend extra hours, working late nights to make sure that the digital data collection happens properly, it is updated properly on the app, and the work is completed. More so beyond doubt, I think there is this sense of workers experiencing what was initially offered as much more of a flexible kind of a work arrangement, where these women workers could balance their day-to-day work, their domestic household and care responsibilities with some kind of voluntary work for the community, has really transformed into a work which is much more demanding, and and their time is being controlled, or their availability is being demanded much more intensively.
And I think going forward, if a digital literacy program is also planned, I think these are some of the important nuances one needs to be aware of when we are also designing certain programs such as this or adapting to. I also would like to now focus on the collective resistance that ASHAs are renowned for. They have been organizing and resisting digital policies that increase their burden without fair compensation. In fact, even getting decent wages for the kind of work they're doing, ASHAs have had a long history of resistance and collectivizations. So, what are some of the key forms of resistance that you've observed, and what lessons can we learn from this collective action?
So certainly, I think it's beyond doubt that the collective of ASHAs has been a real strength for the ASHA workers in many of the states. So, for example, in the case of ASHA workers in Haryana, when the digital push was really made, without really providing the ASHA workers with any kind of resources or any kind of support to make this transition, it was the union in Haryana which started by making the demands for first of all small SIM cards for these ASHA workers with internet. And later, when the push for increased digital work, really became much more intensive, it was the union which again, demanded for smartphones to be given to the each of the ASHA workers to support them in the kind of digital work that they were doing. And this is very, very important because, as I mentioned previously, also these women come from very marginalized communities and many times very poor households, with the very low allowances and honorariums and piece rate incentives which they get, which ranges from something like 4,000 rupees in some state, and which would go up to something like 10,000 or a little more in some other states. For them to really invest money to purchase smartphones, any decent smartphone
Right.
costs somewhere around 10,000 rupees if it has to be able to support all the different digital apps which the ASHA workers have to use. So it was an important moment wherein the union was able to secure these rights for the workers, particularly in the case of Haryana. And what we've noticed in some of the other states, for example, in Rajasthan, the ASHA workers union collective is not as strong. It is much more fragmented. So it has not been able to pick up or mobilize strongly around the issue of the digital transformation of their work. What they picked up, in fact, was how they had this dual accountability to the WCD as well as the health department, which made their everyday working much more challenging. And that's the issue which the workers' union kind of pushed for and made sure that the ASHA workers now solely had to report to the Ministry of Health. In the case of Kerala, I think they have a strong ASHA workers union that has been there. They have been, over the period of years, particularly vocal in pushing for better pay for the ASHA workers, and they have managed to get their honorariums increased over the years, which is close to 10,000 rupees now. And there has been demands for better worker rights all around. They haven't been as such very vocal about digital rights for the ASHA workers as of now, but they are increasingly cognizant that the changes that are coming about in the nature of their work is going to push them more and more into digital.
Thank you. I think very importantly, you've spoken about how the collectivization also has to now adapt to take up new issues such as this digitalization. How the kind of levels of collectivization also impacts your asks for digitalization, as you've said, across the four states. I think these are going to be very interesting questions to look forward to in the coming years as digitalization increases tremendously.
Most importantly, to make sure that any kind of harmful digital practices that might have been,
Right.
particularly digital data practices, that might come into their everyday work is kind of resourcefully resisted and pushed back. What we have seen and what we have kind of heard from the ASHA workers and from their collectives, there is also this hope that comes in, that there is this possibility that we can think about a new kind of a data future based on much more inclusive and participatory practices. Can these workers, can their unions have a role in the kind of digital transformation that is happening in their work? Can we recognize their voices and the wisdom that they hold about these public healthcare systems and how it should be functioning? And can they become partners in this process of digitalization of healthcare systems?
Absolutely, what you just said, being inclusive and being partners to this entire process of digitalization. I think we are all talking about the top down approach that's just not working. And you need to have the people who are doing the work to be partners at the very starting point of, even designing an app that you would want to really capture great data on. And data is gold mine, and digitalization is only going to be more expansive. And it's important that the eyes of the collectives remain that it needs to be inclusive and transformational for the workers themselves. And just flowing from there and towards our last question, policy makers would want, quote unquote, a smart ASHA, but we all know that transformational change takes time, and it needs to be more inclusive in practice and theory as well. So what do you think? What are some of the key takeaways or some key practices, best practices you would think that could be adopted more widely to make digitalization truly effective and friendly for ASHAs?
So, based on the research that we've done, one of the key principles really is to have a much more of a participatory approach. I think these ASHAs are very important and critical stakeholders in our public healthcare system. They have a proven record of having successfully delivered healthcare transformations and good healthcare outcomes in many fields. Why can't we think about a much more participatory approach wherein you bring them in co-creating digital tools that are much more context sensitive, are user friendly for these workers by involving the ushers very much from the beginning in the designing process in a very integrated way. The other thing that we noticed, what a huge difference these tools can make, particularly when they are worker friendly. So we need to develop integrated worker friendly systems like we have seen in Rajasthan's PCTS app, that basically allows and enables the ashas to streamline their work, allows them access to the data that they have collected, which they can use to inform and strengthen the community care work that they are able to do. A precondition for all of this, I think, is more investment in the digital infrastructure itself. And if I may say, also the public health infrastructure more broadly. So we need investments that need to go into it to ensure that we have reliable connectivity and access to good quality devices, because there is no point, asking ashas to collect data and to digitalize their work further and further if the device which they are working does not support the array of apps which they have to use on an everyday basis. Another critical, I think, precondition, and which each of these state who is thinking about making this digital transformation need to think about is, and let me emphasize, make a gender responsive, digital skilling approach needs to be adopted. We need comprehensive digital skilling, which is developed in a way that it tailors to the diverse needs of ashas, which we have been talking about the diversity of the ASHA workers themselves across age, educational capacities, digital skill capacities, language, how particularly the ones from marginalized communities might face many challenges, and how they can be supported and how they can be better integrated into a skilling system which is also able to cater to their specific needs. And all of our efforts in terms of this digital transformation will really not bear any fruits if we are not able to also, along this process, very seriously and committedly commit to the addressing the social norms, particularly the gendered social norms that are there around women's access and use of technology.
Thank you. I think very important points and very important policy recommendations, and very importantly, not to forget the social aspect when you're designing technical aspect. I think it's important when we're talking about women workers, their realities are different, their burdens and challenges and barriers are different. And any digital literacy skilling program or any intervention needs to be mindful of the social barriers and norms as well. And I think it was absolutely wonderful speaking to you, Sreerupa. I think this research is very, very interesting, in depth analysis, and I hope the audiences will now look at the reports as well. There is a comic strip, as I mentioned, to understand more about ASHA's critical work at the community level. There's also an animated movie, ASHA, available on ISST's YouTube channel. Do look them up as well. And thank you so much, Sreerupa. This has been an exceptionally learning journey for me, and I hope the audience also had some wonderful insights and learnings. And please leave your comments below. We would love to hear more from you as well.
Thank you, Anweshaa. It was really, really very rewarding to think and discuss our study with you. Thank you.
Do subscribe and share widely this episode, and look forward to another episode soon. Thank you.